My dear, listen very carefully the topic that I will discuss now. This is the 5-star topic for exam. A bit complicated things are written sometimes in the books and literatures altogether. That is the Cushing syndrome and their causes, and of course their approach to go to the underlying etiology means the localization test. And you will see the how simplest form that can be done to clinch the diagnosis. You'll feel it. Just follow me what is written in your notes. Cushing syndrome causes. ACTH dependent causes are Cushing disease like 80%, that is pituitary tumor secreting the ACTH producing adrenal hyperplasia. So pituitary tumor secreting ACTH causing adrenal gland hyperplasia, causing hypercortisolism. Yes, the diagnosis is 80% causes. So we call this is Cushing disease. Means pituitary gland adenoma releasing ACTH causing the syndrome that we call the Cushing disease. Ectopic ACTH production to 5 to 10% by the small cell lung cancer is another cause of ACTH dependent Cushing syndrome. ACTH independent causes. Iatrogenic, that is the steroids. Next to them, that adrenal adenoma 5 to 10%, adrenal carcinoma, there is the Carney complex syndrome including the cardiac myxoma, and micronodular adrenal dysplasia is very rare. Pseudo-Cushing's mimics the Cushing's due to alcohol excess or severe depression and cause the false positive dexamethasone test or 24 hours urinary free cortisol. An insulin stress test may be used to differentiate. Next point is the Cushing syndrome investigations. Investigations are divided into the confirming the Cushing syndrome and then localizing the lesion. A hypokalemic metabolic alkalosis may be seen along with the impaired glucose tolerance. Ectopic ACTH secretion secondary to small cell lung cancer is characteristically associated with very low potassium levels. An insulin stress test is used to differentiate in between the Pseudo-Cushing's and Cushing's. Tests to confirm the Cushing syndrome are the two most commonly used tests are that is overnight dexamethasone test, that is most sensitive test, and 24 hours pre-cortisol level. Localization tests are the first line localization of the 9 AM and midnight plasma ACTH and cortisol levels. And if the ACTH is suppressed, then non-ACTH dependent cause is likely, such as adrenal adenoma. High dose dexamethasone test. If pituitary source, then cortisol suppressed. If ectopic or adrenal, then no change in cortisol. CRH stimulation test, that is corticotropin releasing hormone stimulation test. If pituitary source, then cortisol rises, and if ectopic or adrenal, then no change in cortisol. Petrosal sinus sampling make a big start here. Petrosal sinus sampling, we call the inferior petrosal sinus sampling IPSS for ACTH may be needed to differentiate between the pituitary and ectopic ACTH secretion. I'd like to discuss and giving the important boxes that will be helpful, my dear. So let's do it. Before going to the Cushing syndrome, I'd like to give another box that is left behind in the additions disease, so that will be helpful. A box, small box, SS box. In additions disease, we have seen the females with the additions disease, they cause the loss of libido. And sometimes the secondary sexual characteristics are lacking. So this lack or loss of secondary sexual characteristics in additions disease is nothing but due to lack of dihydroepiendostinedione. This is important question come up in your exam, my dear. So the box is to remember SS box, additions disease, AD, just write it down, absent and D for dihydroepiendostinediol. So means what I am saying, the SS box once again, Addison's disease means absent dihydroepiendostinediol. That leads to this box so that you can understand why this is happening in Addison's disease, the female person having a loss of libido and loss of or lack of secondary sexual characteristics. I hope that you understood. Now I'll talk about the Cushing syndrome. In contrast to the Addison's disease, means the adrenalitis, means the adrenal gland damage leading to the hypoadrenalism, means hypocortisolism. Cushing syndrome is nothing but hypercortisolism. So what I say? Cushing syndrome is nothing but hypercortisolism. Cushing syndrome is nothing but what I said, hypercortisolism. So this is the important box that we need to remember. I said Cushing syndrome is nothing but a cortisolism. So we need to confirm that hypercortisolism, and the patients come up with the syndrome of hypercortisolism, means Cushingoid phases, right? Means all the syndromes you will see in your some books, but these are not the important questions, so we are not asking. So yes, once again, Cushing syndrome means the C for cortisolism, hypercortisolism. That's we need to prove. So once again, the Cushing syndrome we call that is C as diagnostic test. Make a box equal to ONDST is the best test. What I say? Best test. And also we can do the 24 hours urinary free cortisol. So that is the box for diagnostic test. Diagnostic test means to confirm, to show the evidences of hypercortisolism. So hypercortisolism is the best test. I said the diagnostic test of Cushing syndrome is the ONDST, not the 24 hours urinary free cortisol. So what is the best test or better test among these two? ONDST. ONDST is the diagnostic test. So overnight dexamethasone suppression test is the diagnostic test. We know in endocrine, what happened? In endocrine, in hyperfunctioning gland, we do the suppression test. In hypofunctioning gland, we do the stimulation test. We already have seen in Addison's disease is a hypocortisolism, means hypofunctioning gland. We done the stimulation test, that is the short synaptin test. Now we are talking about the hypercortisolism, means the Cushing syndrome, means hyperfunctioning gland. So we need to do the suppression test. So once again, ONDST is the best test to diagnose the hypercortisolism. Alright? We thought about the diagnosis now. Now we have to go for underlying etiologies or localization of Cushing syndrome. Before going to this, I'd like to give a small box that's really important. Causes of Cushing syndrome most common by the iatrogenic steroid uses for the long list of autoimmune diseases. So we are not talking about these iatrogenic causes. Next to the iatrogenic, the most common cause of Cushing syndrome, box. Cushing syndrome, the box most common is the Cushing disease. Cushing disease means by the pituitary adenoma, and that is 80% cases. Second most common is ectopic ACTH. I am writing EA, so that will be helpful for the discussion. Ectopic ACTH is also 5 to 10%, means these ACTHs come from small cell lung cancer. And third is the adrenal adenoma. This is also 5 to 10%, means adrenal gland tumor can produce. And these are the three important diseases we need to talk and we need to clinch the localization of these diseases where this hypercortisolism happen. Means we will talk now localization test. My dear, you can feel that pituitary adenoma causing Cushing disease, small cell lung carcinoma is an active carcinoma in the chest, and then adrenal adenoma means the abdomen. I am talking once again, Cushing disease means pituitary, adenoma means the brain. Alright? So CD, ectopic disease means the small cell lung cancer in the chest, and abdomen means adrenal adenoma. So I am saying CD, EA and AA. CD Cushing disease, EA ectopic acidity, and adrenal adenoma is abdomen. So somebody can think about doing a scan means scan brain, scan chest, scan of the abdomen means CT or MRI brain, CT or MRI chest, CT or MRI abdomen can give you the localization of the tumor, can make the diagnosis very easily. But there is a question mark. Why? Endocrine is such a disease, it's very slippery one. Slippery means you try to catch it here, it will go to another way, so it's really difficult to diagnose. Number one pitfalls in endocrine disorders. Second pitfalls, you may have done the CT MRI of the brain, chest and abdomen. You may have found maybe a pituitary adenoma. Does not essentially mean that this CD, pituitary adenoma, is producing this Cushing syndrome. Because in endocrine, non-functioning tumor means this is called incidentally finding tumor, means OMA, we call the incidental OMA is more common. So doing the scan and having a tumor in the brain, maybe the pituitary adenoma, in the small cell lung cancer or maybe the adrenal adenoma, doesn't essentially mean that the Cushing syndrome that I have, this is not due to the tumor that you got by the scan. So you need to correlate the endocrine system whether this tumor is really associated with this suppression test is associated or not. That's why you need to do a long list of suppression tests correlating the syndromes are really associated with the tumor. So the scans are done at the later part after having suspicions which localization and which side means the brain, chest or abdomen is responsible or not. I hope that you understood. So what we had found basically, what we do importantly, just look at the board and follow me and write it down in the notes, that will be helpful. We do the suspected Cushing syndrome. Suspected Cushing syndrome for the localization test. We start low dose dexamethasone suppression test. The first test we do low dose dexamethasone suppression test. In a low dose dexamethasone suppression test, we got the two categories of interpretation, suppressed and another is not suppressed. If it is suppressed, that is mean the pseudo-Cushing, and if it is not suppressed, that is means the real true Cushing. I am writing this is true Cushing syndrome. So this is the starting test, that is the low dose dexamethasone suppression, DST will give you the suppressed and not suppressed. What does this suppress means? We are writing serum cortisol level less than 50 and not suppressed means serum cortisol level more than 50. So very simple. So we use the low dose dexamethasone suppression test, 0.5 milligram dexamethasone tablet, alright. For sometimes you're giving the BD dose or sometimes QDS. Alright, and after that we are measuring the serum cortisol level. You don't need the dexamethasone suppression test. What you are doing, just say the LDDST is suppressed and not suppressed. Suppressed means serum cortisol level less than 50, serum more than 50 means not suppressed, means the true Cushing. Pseudo-Cushings mean the causes are alcohol, obesity, sometimes the PCOS, sometimes the anxiety plus depression. So this is the bundle pack of 5 important causes of pseudo-Cushings: alcohol, obesity, PCOS, and anxiety and depressions. So yes, the low dose dexamethasone suppression test is suppressed, means this is pseudo-Cushings, but not suppressed, this is Cushing syndrome, means the true Cushings. True Cushings means CD, EA and AA. I hope that you now got me actually what I am talking about. CD is Cushing disease, ectopic SsACademy and adrenal adenoma. So now what next? The next test, we do the HD-DST. Once again in HD-DST, we are getting 2 categories of results. One is suppressed, another is not suppressed. So what does this suppression and not suppress means? Before going to this, we would love to have a box. Just write it down: pituitary Cushing disease suppressed at HD-DST. This is the another box. It will be helpful to interpret it here. Means pituitary Cushing disease means pituitary adenoma is acting like a normal gland with high dose dexamethasone suppression test. So if it is something like the CD is suppressed at HD-DST, so suppression means the diagnosis CD. If the not suppressed means other 2 diagnoses like EA and AA. I hope that you are getting me. Right? So this is the ectopic SsACademy, this is adrenal adenoma. The next test will be serum SsACademy level. Serum SsACademy can be increased, can be reduced. Increased means ectopic SsACademy, and reduced means, of course, adrenal adenoma. What does it mean really? Serum SsACademy, you feel that ectopic SsACademy, of course in the SsACademy is dependent, so SsACademy will be high. But adrenal adenoma is releasing cortisol, so the negative feedback SsACademy will be suppressed. So that's why the SsACademy is reduced, means the adrenal adenoma and ectopic SsACademy. So we got the 3 important diagnosis localization. So after suppression the Cushing disease we found, so we can do an MRI. We can do ectopic SsACademy for CT chest. We can do the adrenal adenoma, we do a CT abdomen to localize, right? I hope that you got me right, the simple steps. These are so important, my dear. We will write now the pitfalls of this test. Pitfalls means some abnormalities of this test. Number 1 pitfall is pituitary Cushing disease sometimes not suppressed by HD-DST. What I said, the pituitary Cushing disease is not suppressed by HD-DST. So follow me. So if it is something like that, not suppressed, so the diagnosis ectopic SsACademy and AA, if I said this one now, so of course the top of the list will be CD here. So doing an number 1 test LD-DST and number 2 test is the HD-DST having no benefits at all. Altogether here you see the CD, E and A. Not suppressed. We talk about the pituitary Cushing disease. Sometimes, this is the pitfalls. Sometimes the pituitary Cushing disease is not suppressed at the HDDST. So what happened? You see, the C, D, E, A, and A. So if you do the third test, the ACTH level increased means ectopic ACTH, and top of the list, of course, will be the CD will come up here. So now the question here, how to differentiate between the CD and ectopic ACTH, EA. Second pitfall, my dear. Pituitary Cushing disease is caused by macroadenoma. And MRI only pick macroadenoma. So what I am saying, pituitary Cushing disease is caused by microadenoma. I said, sorry, once again I am saying the pituitary Cushing is caused by microadenoma. It's caused by microadenoma. But MRI only pick up macro. Means MRI missed microadenoma. It does mean MRI normal doesn't essentially mean that pituitary Cushing disease is excluded. This is very important. What I said, MRI normal doesn't mean that pituitary Cushing disease is excluded. As I said, the MRI only detects macro, and pituitary Cushing disease is caused by micro. Macro, of course, it will cause the pituitary Cushing disease, but initially they are micro, so they can miss. This is the pitfalls we need to know to localize our diagnosis. Now the problem here. So problem solving, just write it down. Problem solving, just write it down. IPS is sampling for ACTH plus minus CR rate stimulation test is the best test to differentiate in between pituitary Cushing disease and ectopic ACTH. So what I am saying, my dear, very, very carefully just look at the board and follow me. This is very important discussion. You will never found anywhere to make yourself to clear enough. So let me start by localization test. Localization test, first step is the LDDST. So will be suppressed, not suppressed. Very simple. Suppressed means Pseudo-Cushing's. Not suppressed means real true Cushing. True Cushing means C, D, E, A, and A. Do the HDDST. Once again you will get the suppressed and not suppressed. Suppressed means, I said, the box normally, normal response, right? The pituitary Cushing disease usually suppressed at HDDST. So suppressed means CD, and do the MRI, get the diagnosis. But we say the pitfalls, sometimes not suppressed. So yes, not suppressed, top of the list C, D, E, and A. Do the ACTH level is high, get the diagnosis CD and EA. The confusions come up here that IPS is sampling for ACTH and plus minus CR stimulation test. So this is the fourth test. I'd like to talk about this suppressed and not suppressed. What does this suppressed means? A small box will be helpful. What does this suppression means? Suppression means more than 50% of the level, serum cortisol level found at the LDDST. This is called suppression. What does it mean? Let me give you an example. LDDST not suppressed means greater than 550. So we got serum cortisol level 200. So serum cortisol level 200 after LDDST, what does it mean? This is not suppressed, means more than 50. So definitely this is CD, EA and AA. And HDDST after that, suppressed and not suppressed means 200 is the LDDST, I said it, greater than 50% suppression of serum cortisol level found at the LDDST. Means LDDST amount is 200, so half of this serum cortisol level is 100. So less than 100 means we got the serum cortisol level here 90 means suppressed, means less than 100. If it is more than 120, more than 100 means 120, 110 or whatever, 200. So this is called not suppressed. I said the HDDST suppression means greater than half of the amount that you found at the LDDST. That is called suppression. Alright, so very simple. So once again you got the suppress, of course the diagnosis is CD, but you see the pitfalls. Sometimes they don't suppress, so the test will be here. Serum ACTH is high, high means CD and EA, and the differentiating diagnosis, the IPSS sampling for ACTH with or without stimulation of the CRH stimulation test. Inferior petrocell sinus sampling for ACTH. Inferior petrocell sinus sampling is a very invasive test and can be done by super specialized persons. So that is the last test. You feel that inferior petrocell sinus, the draining sinus of the pituitary gland. So pituitary adenoma producing ACTH, definitely you will get the much more ACTH over there in the petrocell sinus sampling. So that's why we do the inferior petrocell sinus sampling test for the ACTH is the diagnostic test for the Cushing disease to differentiate from the ectopic ACTH. And once again, more confirmation, the CRH stimulation test. You give the CRH here, you take the inferior petrocell sinus sampling for ACTH, so definitely CRH will stimulate ACTH more and more, of course pituitary Cushing disease. But CRH, you give the CRH, you take the inferior petrocell sinus sampling, no increase after the CRH injection, so definitely is an ectopic ACTH. So once again, with or without CRH stimulation test is the diagnostic test for Cushing disease, CED. In ectopic ACTH, it will not be happen. Means inferior petrocell sinus sampling ACTH will be reduced. Means not that much. But in CD, ACTH will be high. So the summary talk, my dear, this is very important. I hope that you get through all the steps that we have discussed here. One of the most important hot topic for your exam, my dear. Cushing disease, ectopic ACTH and adrenal adenoma and localization test. So starting, I'm just summary, just forget them altogether. Forget them. I said the number one test is the LDDST. Just look at me, forget them. Start with the low dose DST, LDDST. Suppressed, not suppressed. Suppressed means Pseudo-Cushing, not suppressed means true Cushing. True Cushing means CD, EA and A. Second step, do this test, the HDDST. HDDST once again suppressed and not suppressed. Suppressed means CD, not suppressed means EA and AA. EA and AA do a serum ACTH level. ACTH will be high in EA, low in AA. Done, finished. And do the scan. These are normal. But the pitfalls. Pituitary Cushing disease not suppressed by the HDDST, we know sometimes. So in that case, doing LDDST, doing HDDST, no benefits. You got the CD, EA and A all together, do the ACTH level. ACTH level is high, it is possible in CD, A and EA. So now the differentiating and dilemma is how to differentiate in between CD and EA, and doing this IPSS sampling for ACTH is the differentiating point in between these two. And sometimes it is written in your scenarios that MRI test is normal, doesn't necessarily exclude your diagnosis of pituitary Cushing disease. MRI normal doesn't mean that MRI normal doesn't mean that pituitary Cushing disease is excluded, because MRI can pick up on the macroadenoma, and Cushing disease is caused by microadenoma. Of course, microadenoma can cause Cushing disease. Macroadenoma, of course, will produce. So MRI will detect the macroadenoma that I am talking about. So sometimes we missed microadenoma. So what I say, MRI normal doesn't mean that pituitary Cushing disease is excluded. I'll give an example, and that will be ended up here the lecture soon. The approaches. The summary is talk is low dose DST, HD DST, and then got the diagnosis CD is suppressed and not suppressed in the A and EA, and do the serum ACTH level. High is ectopic ACTH, low in adrenal adenoma. Sometimes pitfalls, so do the IPSS sampling. So the summary talk, if you forget all these things together, you must to remember this IPSS sampling for ACTH with or without CRH stimulation test is the best test. I'd like to give an example that will be helpful to think actually. Alright. Example is, the scenario will give that in LDDST you found the serum cortisol level is 200. In HDDST, serum cortisol level you got once again 200. So what does it mean? LDDST. And they put the serum ACTH level is high. They put the MRI, brain is normal. So let's discuss a little bit more. So serum cortisol level greater than 50 means not suppressed, means true Cushing syndrome. True Cushing syndrome, HDDST done still 200, so half is 100. So this is also not suppressed. So not suppressed means, I said, the CD, EA and AA, pitfalls. Serum ACTH is high, so diagnosis CD and EA. MRI normal doesn't necessarily mean that CD is cut. Does not. Still CD and EA. The question will come up, what test you will do to diagnose your case? Yes, once again you see, the IPSS sampling for ACTH with or without CRH stimulation test is the diagnostic test to confirm whether it's CD or ectopic ACTH. I hope that, my dear, this discussion will be very much effective and fruitful for your whole life, definitely for your MRCP exam. Thank you very much. Thank you once again.